So hey guys, welcome back to Job Studies Made Fun. My name is Dr. Angad Rai and I have scored an All India Rank 9 in the June Fmge examination, and today we're going to talk about Pediatrics Part 3. In this topic of Pediatrics Part 3, mostly we are going to focus on our newborn care. Alright, so let's start. First thing in newborn is we need to know what is the normal birth weight. If you talk about anything which is normal, a normal one would be around 2.8 to 3 kgs, correct? And then a low birth weight is anyone who is going to be less than 2.5 kgs, and then a very low birth weight is going to be anyone who's less than 1.5 kg, and then extremely low birth weight, okay, extremely low is less than 1 kg. Please be careful of these values. These questions have been asked regularly and then they might come again as well. So yeah, make sure that you get this done. All right. So as I wrote over there, remember the basic birth weight classification: low birth weight less than 2.5 kg, very low birth weight less than 1.5 kg, and extremely low. E stands for extreme, all right, okay? Extremely low birth weight, which is less than 1 kg. What is macrosomia, guys? A large baby. How much is the weight? It is going to be 4 kgs. Anything more than 4 kgs is considered as macrosomia. Okay, now the chart over here, guys, which it can come as an image based question, is an intrauterine growth chart. What you need to know in this intrauterine growth chart is there are 3 curves. The topmost curve is going to be large for gestational age, the topmost one. The middle one is appropriate for gestational age, and the last one in the lowermost part is small for gestational age. What you have to remember over here is the value. You will be considering a value of large for gestational age if the percentile is more than 90. You will be considering small for gestational age if the percentile is less than 10, and in between is appropriate. Simple, cool. All right. See, now we will talk about the differentiation between what are the conditions where you see small for gestational age and what are the conditions where you see large for gestational age. First thing in small for gestational age is constitutional SGA. What is the meaning of constitutional, guys? Is basically if the mother itself was a thin built. Now guys, if the mother only was thin, if she only did not used to eat too much food, obviously the baby is also going to be small. So that will be a normal one, which is small for gestational age, which we call as constitutional. Now guys, IUGR, we have learned this in OB-GYN, is intrauterine growth restriction. Now intrauterine growth restriction is a pathological SGA, small for gestational age. Okay, what are the features, they will ask you. Okay, what are the features? The features would be, you will have loose skin folds, you will see on the baby, and you will see signs of muscle wasting. Or if you see wasting can be there, they'll just mention wasting over there. Okay, loose skin folds or wasting. Okay, so this is pathological one, that is IUGR. But this much you have to know in small for gestational age. Next, again, large for gestational age. In large for gestational age, I told you, see, SGA will be less than the 10 percentile and LGA is more than 90, right? So large for gestational age, again, constitutional LGA. Now what is constitutional? If it is an obese mother who is eating too much during her pregnancy, who is already very healthy, her child is also bound to be very healthy. One condition, normal. Second is infant of diabetic mother. Now guys, know this concept of infant diabetic mother. I'll explain it over here also. In infant of diabetic mother, first I'll explain you guys, okay, then we'll write it down. See, diabetes. What is the problem in diabetes? In the blood there is too much glucose, so that is hyperglycemia. Now what is that hormone which is responsible to put glucose into the cell? It is insulin. All right, I'm going to answer also I'm going to be like, giving a gap. So I expect you, whenever you're watching this video, you're answering like, imagining that it's a live session. All right. So as I was asking you, the hormone which is responsible for putting the glucose inside the cell is insulin. So if there is a hyperglycemic state, there will be a hyperinsulinemic state as well. So hyperinsulinemia will be there. Now you guys know that the fetus is connected to the mother with the help of the placenta, right? And there is transfer of materials. Now glucose is also getting transferred, so that's why there will be a hyperglycemic state in the baby as well. And because glucose is going, insulin also will go. So that is why in the infant also there will be hyperinsulinemic state. So now when the baby gets delivered, okay, now when the baby gets delivered, the glucose which was coming earlier from the mother, now that is not getting transferred, but there was initial amount of high insulin already in the baby. So now think about it. Now glucose is not getting transferred from the mother to the baby. but insulin is already very high. So whatever left amount of insulin is there in the baby, it will push it also inside the cell. So in the blood, there will be low glucose. That is why a common complication seen in infant of diabetic mother is that they will have hypoglycemia. Understood? Let's write this down, guys. So in infant of diabetic mother, first we'll talk about the mother. What are the issues with the mother? The mother will have hyperglycemia, right? Because of which she will have hyperinsulinemia. Alright, so because of this will get transferred into the fetus. Hana? So now what happens is, after delivery, the patient, the baby will have very high insulin, but low glucose. But if you see, just imagining if it will have normal glucose. Now this normal glucose is also pushed inside the cell because of very high insulin. That is why the baby will suffer from hypoglycemia after delivery. Okay, I hope this concept is clear. Mother was hyperglycemic, fetus was hyperglycemic during pregnancy. Hyperinsulinemia mother, hyperinsulinemia fetus. After the delivery, the insulin, now because there is no more like glucose to come inside, but insulin is already very high. That is why it will take all the normal glucose also back into the cell. That is why in the blood there will be less glucose, and the patient will start suffering from hypoglycemia. Talking about the normal level, how do you define hypoglycemia in a neonate? In neonates, hypoglycemia will be considered as anything less than 45 milligram per deciliter. You will give them 5% dextrose or 25% dextrose. Alright. Next, guys, talking about the scores in newborn, a very important thing. See, over here, focus on two things. In the PYQ, they can ask you two things. Alright. Assessment of gestational age is one thing, and assessment of physiological status is another thing. Okay, so now you guys know that in obstetrics also we talk about gestational age assessment by the Naegeli's rule. You add 9 months or you subtract 3 plus, like that you do, right? But over here we are talking about postnatally. After the delivery of the baby, we are counting then the gestational age. So to count the gestational age after the delivery of the baby, we use a score which is the Ballard score. Okay, now this Ballard score, to add premature condition as well, is now known as ENBS, which stands for Expanded New Ballard score. Okay, and remember how the question will come: assessment of gestational age post-natally. Alright, it will be after delivery, after birth. That is going to be Ballard score. But if they ask you assessment of physiological status, means how the baby is right now, that you have to mark as Apgar score. Clear? See, in Ballard score they have another 6 factors, neuromuscular factors and all, you know, the heel to know, the scarf sign and all, but that is not right now much important. I haven't seen much PYQs over here related to that, so we can just remember Ballard score and we're good to go. And the new one is Expanded New Ballard score. Assessment of physiological status, that is going to be Apgar score, and Apgar is very important, guys. Okay, Apgar was something which was discovered by a doctor also. Her name was also Apgar, and the mnemonic is also Apgar, right? Okay, so the first A, it's your wish whether you want to remember first as activity, but I remember it by appearance. Alright, so the first A is appearance. Appearance may you have to score. Now see, all this A, P, G, A, R, they're going to score is 0, 1 and 2. Alright, so what you have to see is 0 is very worst condition, 2 is good and all, and 1 is beach guy in the middle. Alright, so let's start first with appearance. The ideal condition is you want to have a pink to red baby, means fully blood, everything is there. Worst case condition is if there is no oxygen, hypoxia is there, full will be blue. And if there is a condition in which your extremities are going to be blue in color, but the trunk is going to be red, that is known as acrocyanosis. So remember, in case of appearance, if it is completely blue, you will give 0. If it is completely pink or red, you will give 2. And if you see the limbs are blue in color, but the trunk is pink in color, you will give 1. So that is A done. P is your pulse. Remember, if the pulse rate is more than 100, you are going to give it as 2. If the pulse rate is less than 100, you are going to give it 1. And if there is no pulse, you will give 0. Alright. Grimace, APG, G for grimace. Grimace basically means if you use a suction or something right through the nose, that irritation will be there, no, or the patient can cry, that is your grimace. If you put like this and there is no movement or nothing, no reaction, 0. If there is little grimace, it should be there, little irritability or little movement, you'll give 1. If the patient starts crying, you'll give 2. Okay, APG. A now will be activity. Now activity, if the patient is completely flaccid, you'll give 0. If there is some flexion, you will give 1. And if there is good flexion and extension, you will give 2. Now the very important question in which many people do mistake is R. R here also in this table which I got, okay, is just written respiration. And this is the very confusing thing, okay, very thing. And this is also, I think this can come, okay. This respiration is not the respiratory rate. This is respiratory effort. Whoever answered this before me, very good. Your concepts are good and clear. Whoever did not answer, now your concepts are good and clear. Okay. Respiratory effort, I'll write it here also so that you will not forget, not rate. Okay, please remember this. It is the respiratory effort. So if there is no respiratory effort at all, 0. If there is some which will be irregular like this, it will be 1. If the baby is crying, now why crying? Because obviously he is breathing, right? So you will give 2. Alright, so we're done with A, P, G, A, R, appearance, pulse, grimace, activity and respiratory effort and not rate. If the score is going to be more than 7, it is good to go. If anything less than 7, you have to do some interventions will be there. Remember, low APGAR score like 3 or less than 3, very severe conditions require immediate management. They are mostly associated with birth asphyxia. Now in pediatrics, wherever you see birth asphyxia and they ask you what is the most common cause of birth asphyxia, guys, your answer for this, for most common cause of birth asphyxia, you have to mark hypoxic ischemic encephalopathy. Hypoxic ischemic encephalopathy. Alright, so that is the most common cause of hypoxia. Oh, sorry. Alright. Okay. Next, guys, we're done with APGAR as well. Now let's talk about temperature regulation. Alright. Now temperature, you guys need to know what is the normal body temperature, guys. The normal body temperature in a baby which will be there is going to be 36.5. It's not 36.5 to 37.5. Anything more than that, not good. Anything less than that, not good. Okay. How do you measure it? You take the thermometer and usually you keep it in the axilla. An easy way, government maybe you're doing this only. Okay. Now, a very important thing is we need to understand what is the mechanism of heat loss in newborn, because that's why we're talking about hypothermia over here. Hypothermia is much, hyperthermia very rare. In fever and something like this will happen, but hypothermia, because the baby still hasn't had the adaptation, it still does not have the proper mechanism to get it done. So we have to protect it from hypothermia. For this, I have this example. Please bear with me. We'll do it with this. All right. So the first method which is there, okay, first method which is there is when there is dissipation, loss of heat through a large surface area. Okay, large surface area, for example, is a head. That will be is your radiation. Okay. Then second thing is, if this thing is on contact with the table, the loss of heat due to touch, contact, that is contact. Remember the rhyming. I'm trying to rhyme it out. Okay. The loss of heat due to touch, contact is conduction. Okay, the loss of heat because of contact is conduction. Then loss of heat due to the air around, is convection. Loss of heat due to the air around is convection. Then is loss of heat because of water, that is evaporation. So what did I say? If it is going through a large surface area, radiation. If it is through contact, conduction. If through air, that is convection. And if because of water vapor situation, that is evaporation. The question which comes over here, guys, PYQ is, what is the major mechanism of heat loss? Okay, your answer will be, whoever knows it, again, very good, radiation. Okay, your answer is going to be radiation if nothing is marked right here. So radiation. All right, your answer is going to be radiation. And if they will ask you what is the area where maximum heat loss via radiation occurs, that is going to be your head. Okay, head, because of the large surface area. That is why you notice one thing, immediately after delivery, if any hypothermic patient is, we are always going to cover the head. Okay, so I hope you understood this mechanism of loss. Remember the normal temperature 36.5 to 37.5. The most important is going to be radiation. Radiation कहाँ से होता है? Head से होता है. ठीक है? Convection is air. Conduction, contact is conduction, contact, and with water, evaporation. Next guys, let's talk about hypothermia. Now hypothermia is anything less than 36.5. So there are three stages guys: initial stage, moderate stage, and severe hypothermia. Initial stage guys is also known as cold stress. ठीक है? The value will be anything between 36 to 36.4. Okay? Moderate stage guys is something which will be having from 32 to 36 degrees Celsius, right? And anything less than 32, that is going to be your severe hypothermia. Now what the question comes is, how are you going to manage it? If you have a stable baby yani vitals are stable, baby is crying, ABGAR was good to go and stuff, then you notice there was hypothermia. In a term baby, what you are going to do is, a term baby is good to go, everything is already developed. So what you will do is, what I told you, the maximum loss of heat is through the head. So what you will do? Cover the head, the main thing that is there. Okay. In a preterm baby, now over here what you are seeing there, this is known as kangaroo mother care will be there, right? So kangaroo mother care is done in a stable, not in an unstable, in a stable preterm baby. Now what are the questions which are there in kangaroo mother care? Let's talk about that. Okay, first of all is kangaroo mother care is via skin to skin contact. The baby is upright in position. And what will be the feed during your the kangaroo mother care or anything? Remember, the baby's most important food is breast milk. So what do you see? Exclusive breastfeeding. Okay. Now the question which comes over here is, what is the mechanism of action, the MOA in kangaroo mother care? See, as I told you, skin to skin contact. So what did I say? Contact. Answer is going to be guys, conduction. So this is also a PYQ. They'll ask you, what is the mode of mechanism in case of kangaroo mother care? That is through contact, that is conduction. Now another mother care, see guys over here, you see there is a female over here, right? So there was a question that kangaroo mother care is only done by mother. Is it true or false guys? False. Why? Because the mode of action is what? Contact. So don't you think a father or any other guardian can do it? Obviously they can do it. So if any question comes like that, na, which you're like, yaar, ye to padhaya nahi tha, try to use common sense, है ना? कि it was a contact wala related. So obviously even heat, the husband can dissipate, any guardian can dissipate, anyone can do it. Okay. Feeding is exclusive breastfeeding, and the position is going to be upright. When do you stop kangaroo mother care guys? It is stopped once the baby attains a weight of 2.5 kg and the gestational age of 37 weeks. Okay, yalla. Now let's talk about the hemodynamically unstable child in case of hypothermia. Now the two things which you see over here guys, this is a incubator, and guys this is a warmer. Now I will tell the mode of action, you will tell me the mechanism. Over here guys, this is a closed thing. In case of transportation also of a baby, you will use an incubator and not a warmer. Here the air is going around and that is responsible for giving the heat. So if this is air wala thing, so what is the mode of action guys? Convection. Okay. Over here through a large surface area, they're going to transfer over here, and the process in case of a warmer is radiation. Okay, so please remember this, the mechanism of action in case of a warmer is going to be radiation, while because of the air circulating around in case of a warmer, in case of an incubator, the air circulating around, that is going to be your convection. Okay, done. See guys, you might notice one thing, it's very crisp and concise notes, and this is what I studied to get my rank. Okay, I scored I scored 221 in my June examination. It was a very tricky, a long lengthy based questions. So what I expect from you guys is, if you you haven't done peds or you're not able to buy any out of this, do this. But not only this, what I want you to do is do this. 5 years of NEET PG, 5 years of Fmge, and 3 years of INI. You will find out whatever I'm discussing is already there. Okay, and you will feel like, yeah, this you will get the sense of confidence also, and it is more than enough. All right, moving on. let's talk about what are the findings seen in a newborn. Over here, if you see, the patient has, what are this, if you talk about derma, okay, this is going to be red, papules can be seen, and even some pus fields, so you can see pustules, right? Guys, this condition is erythema toxicum. Remember, it is written toxicum over here, but this is a misnomer. It is also known as erythema margi, oh sorry, not erythema marginatum, erythema neonatorum. Whoever was following with me now, when I was saying erythema margi and this in atom, thoda see, like this is that the thing, don't get directly influenced like this. Try to understand, keep logics and stuff like this, because even during the examination, sometimes there will be a very long paragraphical question in which they're directing you to somewhere else, but we have to be very aware to answer what we are, what is the correct answer, huh? So this is erythema toxicum, also known as erythema neonatorum, okay, and this is a completely benign condition. Don't worry, say the mother it is completely okay, she will be alright, the baby will be alright, okay. Over here you see white spots on the nose, guys, this is malaria. Okay, this is R, alright, R. And over here, guys, this is some like first what we'll talk about derma also in a different section. But if you define this, these guys, this are your macules or patches, Hana. It is also known as dermal melanocytosis. This is your Mongolian spots. Okay, all these three conditions which I explained right now, these are benign conditions. Treatment is reassurance. Okay, now guys, let's talk about a very important topic, that is head swelling. So many times this question has come. So let's talk about caput succedaneum and cephalhematoma. Very easy, but like people get confused in this. So remember this, how I'm going to teach you. Okay, see, I have a cap for this to explain. Look, whenever I wear a cap, I am going to wear it in my head or on my head. It is superficial, Hana. First thing is, it is superficial, and you see, am I wearing my cap like this or am I wearing my cap like this? It is completely covering my head. So this is diffuse. So how do you write this? First of all, location is going to be diffuse. And what did I say, guys? Superficial or deep? It is superficial on the top, Hana. Superficial. Okay. The reason of, if you see cap, good. If you see the reason of caput succedaneum, the reason of caput succedaneum is prolonged labor. Now because of this prolonged labor, guys, what happens is there is increase of hydrostatic pressure in the head. Because of increase of hydrostatic pressure, there is venous congestion. And because of venous congestion, there is increased extracellular fluid outside. So because of this increased extracellular fluid, that's why you see that bulge, which will be there around diffuse and superficial. Okay. Next, if you ask you what is the content, guys, content I said you is extracellular fluid. When do you see this? You see this immediately or after some time, like within a couple of hours, after a few hours. Okay, are there any complications, guys? Nothing is there, no complications, because this was just venous congestion. There was excessive extracellular fluid because there was increased hydrostatic pressure, so it pushed it outside. It will come back to normal. Okay, next condition, guys, cephalhematoma, exactly opposite. Remember what I said? I'll remind it one more time. Cap. So when I wore a cap, I wore it complete, so it is a diffuse thing. I wore a cap on my head, it was not in my head, so it was superficial. Cause of caput succedaneum is, guys, because of prolonged labor, increased hydrostatic pressure, venous congestion is there. That is why extracellular fluid is outside. Is there any complication, guys? None. Now cephalhematoma, guys. Hematoma means blood. So there is blood. So there is some issue. So why there is a blood? There was a trauma. So what was the guys? Look, reason was traumatic instrumental delivery. Okay, traumatic instrumental delivery. The location now is exactly opposite. So remember one thing is key, it will be here now. It is going to be localized and deep. Okay. Remember one more thing also. does not cross suture line, and this one crosses. Why? Because it is above, it is not subperiosteal, है ना? Content over here is going to be, because it is a trauma and word is also saying hematoma, so this is going to be blood will be the content. And appearance, guys, this will not happen immediately. Over there in the OT, it will be like, it was okay, everything was okay. But then after around 8 to 12 hours, you will see the changes will be there. Cephal hematoma will be there. Okay. Are there complications? Yes. What is the complication? Because of hemolysis, guys, patient will have jaundice. Okay. So is this clear, guys? Cephal hematoma and caput succedaneum. Okay. Now, guys, let's talk about neonatal reflexes. You guys need to know neonatal reflexes is also called as primitive or immature reflexes. Now over here I'm going to talk about one specific reflex which was asked multiple times, that over here where a baby all of a sudden you just push him back, all of a sudden he goes hands like this. That, guys, is Marrow reflex, also known as startle reflex. Now what they will ask you guys is what are the components seen in Marrow reflex. So what I did was I went like this and then I came back like this. So there is extension and abduction and flexion and adduction. What are the components, guys? Extension and abduction. After that there was flexion and adduction. Correct? How long does this last, guys? It lasts for 5 to 6 months. Okay. Now let's talk about the abnormalities, guys. If you find out that when you check for reflexes, you find out that the Marrow reflex is absent during birth. The most common cause of absent Marrow reflex at birth is birth asphyxia. And guys, what is the most common cause of birth asphyxia? I already told you, that is hypoxic ischemic encephalopathy. If there is unilateral reflexes, now if means one hand is there and one hand is not able to do. One cause, guys, can be fracture of the clavicle. Another cause can be injury to the brachial plexus. Okay, so this is